മാം ജോയിൻ ചെയ്തോ?
Yes, ma'am. Hello, join ചെയ്തു.
നമസ്തേ മാം, നമസ്തേ മാം.
Okay.
Shall we start the session?
Okay, we can. Good evening, everyone. A warm welcome to all of you as we continue our webinar series Srishti on genetics and embryology. It's truly wonderful to see such enthusiastic participation, and we appreciate your dedication to learning. Today, we are privileged to have with us Dr. Geeta Jayachandran, MD in Anatomy and Associate Professor at Government Medical College, Paripalli, Kollam. Dr. Geeta is an expert in anatomy and embryology with extensive experience in both research and teaching. She is a prominent medical teacher with the ability to simplify the complex concepts and great academic excellence. In the previous three sessions, we had insightful discussions on embryology, and today, in part 4, we look forward to expand our knowledge under her guidance. Without further delay, let's welcome Dr. Geeta ma'am to begin today's session. Ma'am, over to you. So we were in the embryonic period, and today we will be continuing with the fetal period also. And the recap of the last week, we were seeing that during the embryonic period, all the germ layers were laid down, and various germ layers were developing into different structures. So the ectoderm has developed into neuroectoderm, and the neural tube is formed with the neural crest cells and also the surface ectoderm. So the ectoderm has given rise to neuroectoderm, which later goes to form the neural tube, and the neural crest cells which migrate to different areas to form different structures, and the surface ectoderm that forms the skin of the embryo. And coming to the mesoderm, we have seen that it is divided into three parts: the paraxial mesoderm lying on either side of the notochord underneath the neuroectoderm. Then you have the intermediate mesoderm that forms the genital sex glands and the kidneys, and lateral plate mesoderm with intraembryonic coelom, which forms the body cavities. And with the intraembryonic coelom formation, we know that the lateral plate mesoderm is forming two parts, that is the somatopleuric and splagnopleuric mesoderm. And it is in the splagnopleuric mesoderm we have the development of the heart and blood vessels. And the endoderm, and it is that endoderm forms the lining of the gut tube, and from the gut tube extends the respiratory system. So along with the gut tube, endoderm also forms the lining of the respiratory system. And so only the endoderm form the lining. The other structures are formed from the lateral plate mesoderm, that is the splagnopleuric mesoderm. So we'll go to that picture again. The first picture where you are seeing it from the surface, and you can see the cut end of the amnion over the end of the ectoderm, and this is the primitive streak, and from there you have the notochord, which induces the surface ectoderm to form the neuroectoderm, and later the neural plate or the medullary plate deepens down with the formation of the neural tube, and light cells meet the light cells, and so the surface ectoderm continues, and the neural crystals it's formed between the neural tube and the surface ectoderm, and that is it. And here in this diagram, you can see the fusion of the neural tube from the cervical region going cranially and caudally with the formation of the finally leaving the anterior neuropore and the posterior neuropore to close late. As a result, you can know that this area, it is the amniotic cavity with amniotic fluid. So it can, the amniotic fluid can run in this canal. So it can nourish the neural tube also. And the intermediate meso, sorry. And here you can see the, in this picture, you are seeing the neurectodome going deep, and meanwhile the sides, you can see the paraxial mesoderms that is forming somite from craniocaudal region. And we have seen that there is pre-somatic period and post-somatic period, along with the somatic period, which extends between the uh, 20 to 30th day. Okay. So coming to this picture, you can see that the intraembryonic mesoderm spreads along the whole length. You can see this red area which extends the whole length except in the midline, where it is not allowed to pass through because of the precorder plate, which is the oropharyngeal membrane, the notochord, and the primitive streak, which is leading to formation of this intraembryonic mesoderm, and also the cloacal membrane. Again, it is a bilamina layer. So this is the lateral plate mesoderm that spreads laterally and continues, and it is limited on the side by the amnioectodermic junction. This is the amnioectodermic junction. So what happens to the, this is the intermediate mesoderm, lateral to the paraxial mesoderm, and it, I have already said, it develops into the sex glands and the kidneys. What about the lateral plate mesoderm? This lateral plate mesoderm, it is continuous on the sides outside the embryonic disc with the extraembryonic mesoderm. So first xylem, which is actually horseshoe shape. Initially, that is limited to the disc, but uh, opens coelomic to nourish it. And this pericardial cavity is continuous on either side with the coelomic canal, but later with the development of the, you will have the pleural cavity which divides its peritoneal membrane. So that was the initial stages, and now we'll come to the orientation of the embryonic disc. The cranial most the development of the so when you remove the ectoderm, you will get hello an issue.
Excuse me, ma'am. Ma'am, your voice is breaking in between.
Hello, can
Ma'am, we can hear you, but it's cutting in between, not
hello,
so clear.
hello.
Yes, ma'am. Your voice is breaking.
I think there is some hello.
Yes, ma'am.
Okay. So we have seen in this embryonic disc the cranial most area. This area, we are seeing this area after removing the ectoderm. So with the ectoderm, some part of the intraembryonic mesoderm also has been removed. Okay, so that part which goes with the ectoderm, it is the somatopluric mesoderm. In so below that you have endoderm. So in relation to the endoderm, there is a little bit of mesoderm, that is the splagnopluric mesoderm. So but in this area, there is no division. This splagnopluric, there is no division of intraembryonic mesoderm. There's only no subdivisions. So this area, it is called septum transversum. And so when you go from cephalic end to caudal end, cranially you have the septum transversum, then the pericardial cavity, then the precaudal plate, which is the primitive mouth where you have the primitive buccal membrane or buccopharyngeal membrane. Then you have the neural tube, then you have the regressing primitive streak and the cloacal membrane. So now we will go to the folding. Before that, this one also. So this is the cardiogenic area. Means what? It is the splagnopluric mesoderm below the pericardial cavity. The pericardial cavity, the intraembryonic coelom is not shown. This is the splagnopluric mesoderm that is shown, and in the splagnopluric mesoderm you have all the blood vessels developing. So this is the blood vessels developing, and this is the cardiogenic area where you have the heart developing. So in this next picture, you can see all the blood vessels developing in the embryonic disc. In this picture, you can see the notochord, the surface ectoderm is getting induced by the notochord to form the neural tube, the somatopluric mesoderm, and small islands of blood islands develop, they fuse to form blood vessels. So this is the transverse cross section, side to side cut. in the next picture, you are seeing the craniocaudal cut. The craniocaudal cut. So here you have the amniotic cavity dorsally. You have the neural tube, the neurectodum getting developed. And here you can see that the two layers, the ectoderm and mesoderm, is closely adherent. You can see the coelomic cavity, that is the pericardial cavity, cranial most pericardial cavity, and in the splagnopluric mesoderm, you can see the developing heart tube. The area in front, it is called the septum transversum. So from cranial end, we have septum transversum, the pericardial cavity with the developing heart tube on its ventral aspect, the buccopharyngeal membrane, then in the midline, the developing neural tube, and here you can see the forming or again a bilamellar membrane, that is the cloacal membrane, and know this orientation only, you will be able to understand the folding. Then you have the cloacal dorsally. So because of the, you can remember, just imagine a sheet-like thing which grows in the middle. If a sheet structure grows more in the middle, it has to fold. Otherwise, the structure will tear in the periphery. So because of the rapid growth of the neural tube, the cranial part, that is cranial to the front cranial end of the neural tube, will bend ventrally. Like that, the part dorsal to the caudal end of the neural tube again will bend ventrally. So this bending is due to the firmness of the neural tube and the underlying notochord and the primitive string. Because of these structures, there is cranial fold and caudal fold, also called the head fold and the tail fold. This is the craniocaudal folds. Like that, because you have somates developing on either side of the neural tube, there will be lateral folding. So as a result, you have four folds, that is cranial fold, caudal fold, and two lateral fold, which converge on the ventral aspect of the developing embryo. So we'll go through each picture. This is the picture which I have said. You have septum transversum, the heart tube with the pericardial cavity on its dorsal aspect, the buccopharyngeal membrane, the developing neural tube. Then you have the primitive streak here, the cloacal membrane, and the connecting stalk. So you can see the arrows going towards the ventral. This is the yolk sac is situated ventrally. So of the structures seen cranially and caudal to the neural tube. It is from the head fold is occurring. So what will happen? The here first moving caudally, moving still caudally. So we will see once more. See once more. This is septal transversum. The pericardial cavity with the developing heart tube ventrally, the buccal membrane. It has bent. So what has happened? It is the buccal now first. Next comes the pericardial cavity and the heart tube. But what's the relation of the pericardial cavity and the heart tube? Initially, the heart tube was on the ventral aspect. Now it is on the dorsal aspect related to the pericardial cavity. The heart tube is dorsal. In the first picture, it was, sorry. In the first picture, it was dorsal. Now it has, sorry, ventral. You can see that is ventral, but here in this picture you can see it is dorsal to the pericardial cavity, and the septum transversum, which was cranial most, has come still towards the ventral aspect of the, and it is the third structure. Okay, now what is the relation of the bilaminar buccopharyngeal membrane? Now we can see the buccopharyngeal membrane is actually the cranial most, isn't it? So this buccopharyngeal membrane is related cranially by the developing brain and caudally by the heart, developing heart. That is called the pericardial bulge. So the buccopharyngeal membrane now lies in a depression called proctodium, stomatodium, and it is bounded by the developing neural tube cranially and the developing heart, which is the pericardial swelling, and this depression is called the stomatodium. And into the gut. Membrane. So as a result of this cranial fold, what happened to the yolk sac? You can see that yolk sac that is relatively big in the initial stage compared to the embryonic disc. It was a big structure, and it is now partly enclosed within the head fold. Okay, so this part of the yolk sac that is going inside the fold, cranial fold, it forms the foregut. Now coming to the caudal tail fold. Here also the same event occurs. The first one, cranial most, was the primitive streak followed by caudally by the cloacal membrane and the connecting stalk with allantois. So as a result of the tail fold, what is happening? The connecting stalk will be the cranial most. Then with the after that you have the cloacal membrane, bilaminar cloacal membrane, and that is situated on the ventral aspect of the embryo. Okay, and this is followed by the primitive streak. So the caudal most thing is the primitive streak, which is regressive. And the part of the yolk sac that is inside the tail fold, it forms the hindgut. So you know that the gut from the gastrointestinal lining tube, it is the endoderm, and partly it is formed by the intake of the yolk sac inside the tube. As a result of folding, the flattened embryonic disc will become tubular, and this tail fold, cranial fold, the caudal fold. Now, this is seen craniocaudal direction. We were dealing with the craniocaudal. Now coming to the lateral, this is transverse section. You are taking a transverse section. So when you see the transverse section, what is happening? It is the somites that is responsible for the lateral folding. So this is the paraxial mesoderm developing, and you have intermediate mesoderm followed by the lateral plate mesoderm, where you have, this is the
Excuse me, ma'am.
the lateral fold is converging ventrally. So what is happening?
Ma'am, you.
Yes, can you hear? You're not
No, ma'am.
audible?
No, ma'am. It's actually breaking.
Now I am audible? No?
Yes, ma'am. Now it's clear.
No.
So
Yes, ma'am. It's audible
have
now.
you heard about the craniocaudal okay. Craniocaudal folding you have gone through? Have you heard about that?
Yes,
Hello?
ma'am. That was clear. That was clear, ma'am. Just for a few
Okay.
minutes or 2 or 3 minutes, it was breaking, ma'am.
Okay. Now this one, this picture, this set series of pictures, we are doing taking it in the transverse section. This was from head to tail. Then this is from side to side. So we have the neural tube with the notochord inducing it. On either side of the neural tube, we have the somites, the paraxial mesoderm, which is responsible for this lateral folding. Okay. And this is the intraembryonic coelom with the ectoderm. Some of the mesoderm is there. That is the somatopleuric mesoderm, which will form the body wall, the connective tissue, the skeletal elements of the body wall. Whereas the splagnopluric mesoderm is those structures that forms the smooth muscle, the connective tissue parts that connects that is surrounding the gut tube, because so this is the splagnopluric mesoderm. This folding, the lateral folding, it is due to the development of the somites. And as a result, you can see that part of the yolk sac is inside and part is outside, connected by a duct. Now, in this diagram, this is the somatopleuric mesoderm. This is the splagnopluric mesoderm. Here, this is the splagnopluric mesoderm. This is the somatopleuric mesoderm. Getting it? Once more, this is the ectoderm. This is the transverse section. This is the ectoderm, intraembryonic mesoderm, the paraxial mesoderm. You have a small intermediate mesoderm. This is the lateral plate mesoderm with the coelom, intraembryonic coelom. And we have said that the intraembryonic coelom communicates with the extraembryonic coelom. And this pink color area with the ectoderm, it is the somatopleuric mesoderm. The splagnopluric mesoderm along with the endoderm, that is the mesoderm along with the endoderm, it is the splagnopluric mesoderm as a result of this folding. You can see that the yolk sac is being reduced into size, and part of it is going inside the embryo, part of it is going inside the embryo, and part is outside. And it is connected by a duct. This outside yolk sac outside the embryo form the umbilical vesicle, and this duct forms the vitellointestinal duct. So once more, so this somatopluric mesoderm is this somatopluric mesoderm. Getting it? This somatopluric mesoderm is this somatopluric mesoderm that forms the body wall. This splagnopluric mesoderm, this is the endoderm. So that forms the this forms the splagnopluric mesoderm. So the gut is suspended by this splagnopluric mesoderm. The dorsal mesentery is from this splagnopluric mesoderm. The wall of the gut tube is formed by splagnopluric mesoderm, whereas the lining of the gut tube is formed by endoderm. So now we have two lateral folds. You have the cranial fold, the caudal fold. All this will converge into one area that will forms the this area, umbilical ring, this area. So because of the fold, because of this fold, this area, it forms the umbilical ring. And what all structures will be there in this umbilical ring? You will have the connecting stalk, the vitellointestinal duct, the allantois, part of it which regresses also will be there. So these umbilical ring. So as a result of this lateral fold, the part of the yolk sac that gets in, it is forms the midgut. So you know that now you have understood how the foregut is formed. The foregut, it is within the cranial. You can remember, think of yourself, the septum transversum, it develops into the diaphragm, which was initially the cranial structures. Now because of the folding, it has come to the mid trunk position, and the septum transversum uh, along with the pleuroperitoneal membrane will form the diaphragm, so that the cavity of the embryo is divided into pleural cavity and the peritoneal cavity. So here you can see this is the intraembryonic this area, it is the extraembryonic coelom. So there is a transient connection between the extraembryonic coelom and intraembryonic coelom. Later this will get closed. You can see that it is getting joined, and this part will become the umbilical cord. Now, in this picture, here you have the amnion. Here you have the amnion. This is the amnioectodermal junction. Now, with the folding and the enlargement, because of the folding itself, this amniotic sac will get enlarged, and the amniotic junction will move closer towards the ventral part of the embryo because of the folding. So 4 and the endoderm will be inside with yolk sac, most of it inside, with a little remnant that will be seen in the umbilical cord as the vitellointestinal duct. And this persistence of the vitellointestinal outside in some stage of development, that is called the umbilical hernia. Come to it. So again, this picture, you can see the reduced yolk sac, the change in orientation of the cranial and caudal structures. This is the lateral folding. And here you can see, once more I am telling this, this is the intramyonics, the gut tube with the splagnopluric mesoderm. This is the intermediate mesoderm, which now lies in the cavity of the embryonic coelom. That is the peritoneal cavity, in future peritoneal cavity. Its size lies as if it is on the posterior wall. It is due to this folding. Now, this was the initial yolk sac. Because of the head fold, you have foregut. The derivatives of the foregut are the pharynx, the esophagus, then the respiratory tract, then the stomach, duodenum, half of it. From the midgut, I have the rest of the half of the duodenum, jejunum, ileum. Then comes the ceca, appendix, ascending colon, transverse colon, right two-third. When coming to the hindgut, you can see that this hindgut, the allantois, which was inside the connecting stalk, because of the fold, has come to the ventral aspect of the hindgut, thus dividing the hindgut into pre-allantoic part and post-allantoic part. The post-allantoic later a septum, this endodermal cloaca, and divides into that septum is called the anorectal septum, which divides into urogenital part anteriorly and the anal canal posteriorly. So you have the cloacal membrane initially in the anterior aspect of the actually it was initially in the anterior aspect of the folding tail fold, but later with the, likewise we have seen that the foregut, the stomodium and the pericardial cavity are very close in the initial picture. Later what will happen is, with the development of neck, which is due to the development of pharyngeal arches, the heart will be pushed away from the mouth, developing mouth. So what is Meckel's diverticulum? So I have said that the yolk sac that is reduced in size, partly included as the gut tube, and partly it is outside as the umbilical vesicle, and it is attached by a narrowed part which digresses later, which is the vitellointestinal duct. Normally it disappears, but it can persist at different level. In this picture, you can see that the midgut, it is connected to, this is the umbilical region. It is connected to the umbilical region. Through the umbilical cord, you have this vitreointestinal duct. It can persist close to the midgut, or it can persist close to the umbilicus, or it can become as a whole. It can be a patent thing. So if it is patent as a whole, you will have the contents coming out of the gut, coming out through the umbilicus. That is will be a fecal fistula. Or it can be seen in patent close to the gut tube alone. Then it is called a Meckel's diverticulum, and it may present with features of appendicitis, as it may contain some um, um, pancreatic tissue or lining epithelium of the stomach. So it may produce inflammation, and it may mimic as a appendicitis. Or it can be patent close to the umbilicus alone. That is called the raspberry tumor. So that is folding of embryo. Head fold is due to the rapid longitudinal growth of the neural tube, whereas the tail fold is also, it is due to the rapid longitudinal growth of the neural tube, which gives a firm base for the fold, whereas the lateral fold is due to the growth of the uh, somites. All these folds converge ventrally at the region of the umbilical ring. So the umbilical ring, where you have the connecting stalk, which later form the umbilicus, will also be covered with amnion, and with the fold, the embryo will be floating in the amniotic fluid. So we were seeing about the embryonic. So hope you understood the events there. How the flattened disc has now become into a tubular structure. And now the tubular structure, you can just imagine that the cranial end, you have the developing neural tube, but it is covered by the skin, where you can get the ear vesicles, you can get the uh, otic vesicles, the lens plecord, the eye vesicle. Then they will be developing on the face. Okay. So at the beginning of the fourth week, the straight embryo will have 4 to 12 somites, and the neural tube will be open with anterior and posterior neural pore. And I have said about the development of the neck, and there the development of neck is by the pharyngeal arches. These pharyngeal arches are 6 in number initially, which reduce into 5. And with the development of the neck, you have the pushing down of the developing heart into the normal position. With the tail head fold, you can understand why the heart, which was in the cranial part, has come to the ventral aspect. And its relation with the pericardial cavity. Now, coming to the effect of tail fold, also I have said the heart and pericardium has moved caudally. The septum transversum lies caudal to the heart, and head with brain occupies the cranial most end. So in this picture, you can see this is the embryo that lies in the amniotic cavity. This is the amniotic cavity, which was small, lying on the dorsal the embryo from all the aspect, because now the embryo is fully covered with ectoderm, and the endoderm, which was on the ventral aspects, has gone partly inside and some little bit outside to get regress later. The buccopharyngeal membrane or the procaudal plate lies cranial to the heart. Effect of tail fold. The allantois opens in the hindgut, which was initially in the connecting stalk, which divides the hindgut into pre-allantoic and post-allantoic. The yolk sac neck narrows, the connecting stalk and yolk sac lies between the head fold and tail fold uh, ventrally, and on other side between the lateral folds. The amniotic cavity covers the embryo almost completely and it expands. So by now you must have understood where the heart is, where the septum transversum is. Septum transversum develops partly into the diaphragm, and partly lower down you have the development of uh, the liver inside the septum transversum. Septum transversum is a part of mesoderm, but the developing liver is the parenchyma, the liver tissue. It is actually outgrowth of the endoderm. From the endoderm, from the gut to the parenchyma of the uh, parenchyma of the liver get into the septum transversum. That the tissue, it is from the endoderm, whereas the connective tissue part, it is from the septum the connective tissue part of the liver, and also some other tissues are also formed from the septum transverse. Okay, and the buccal pharyngeal develops into the future uh,
Excuse me, ma'am. Your voice is breaking again, ma'am.
but the roof of the mouth, the paranasal sinuses. Again, you come here. Hello. Hello.
Ma'am,
You
ma'am,
can hear?
ma'am, we can hear you, but your voice is breaking a little.
Hello.
Yes, ma'am, we can hear you.
Okay. So, so the buccopharyngeal membrane lies in the depth. So what will happen is the mouth, primitive mouth, it is ectodermal. You can see this is ectoderm. This is ectoderm, and this part is ectoderm. Okay, and the roof of the mouth, the cheek of the mouth, the uh, enamel, the paranasal sinus, the nasal cavity, all those are ectodermal, whereas the tongue, it is endodermal in origin. Now we can see that the gut tube is ventral to the neural tube. The foregut, it is dorsally, spinal cord. You know, the yolk cell connecting converted into umbilical cord. The umbilical cord with the regressing vitellointestinal duct. It is there from the yolk sac. You have that is divided into post-allantoic and pre-allantoic part, and the post-allantoic part, it is the urinary bladder partly, and post it will form the anal canal, not completely, partly. Little bit of it, it is the lower end of the orifice is ectodermal, like the oral cavity. Some contribution, it is from the ectoderm. So the amniotic membrane also covers the umbilical cord. So the outer covering of the umbilical cord is amniotic membrane. So again, lateral fold. This is the paraxial mesoderm, the lateral plate mesoderm. This is the somatopluric mesoderm. This is the splagnopluric mesoderm. This is the intraembryonic coelom. This is the extraembryonic coelom, which it communicates because of the lateral fold, converging ventrally. The connection between the intraembryonic coelom and the extraembryonic coelom get cut off. So once more, this is splagnopluric mesoderm. This is the gut tube. This is splagnopluric mesoderm. So this is the splagnopluric mesoderm. This is splagnopluric mesoderm. So what is happening? The gut tube is hanging from the dorsal wall of the embryo by dorsal mesentery, which is splagnopluric mesoderm. Once more, this is somatopluric mesoderm. This is somatopluric mesoderm. Okay. This is splagnopluric mesoderm because this is the gut tube. This is the endoderm. This is the yolk sac. So this will be the splagnopluric mesoderm. This will be somatopluric mesoderm. This is the area of intermediate mesoderm. This is the area of intermediate mesoderm. This is the area of intermediate mesoderm. Now we can understand that the intermediate mesoderm is bulging from the dorsal aspect of the coelomic cavity. This intermediate mesoderm develops into the kidney and gonads. The gonads later descend into the normal position. And female, it is in the pelvis, and in the male, it goes. Is this omphalloenteric vitelline duct? It has different names. So you can, if it may get this in vitellointestinal duct, but it usually regresses, so it is not seen in the in a fully developed umbilical cord. It may not. It can be. So in week 4, we are in the embryonic period till now. So the rostral neuropore closes in the 4th week. The 4 brain vesicles become prominent. The embryo will become curved inside, and it becomes C-shape. Now you can imagine that the tubular embryo will have the somites on the position of the somites. Just think of it on your dorsal aspect. Think of your body itself. On the dorsal aspect, you have the somites, and at that end, at that area where the cervical from the 4th cervical to the thoracic 2nd somites. Thoracic, we have said of occipital somites early, the cervical somites, we have 8 cervical somites, we have 12 thoracic. So at that region, a bud arises. That is the upper limb bud, which appears first compared to the lower limb bud. That bud extends as a pad, and the distal end of the end of this limb bud will become flattened to form the hand pad or the foot pad. If it is in the lower limb bud, which arises same as the upper limb bud from the dorsolateral aspect of the tubular embryo, this bud will come out as 90-degree, and the distal end will be flattened to form the foot pad or the hand pad. And later in this foot pad distal to distal end, 4 ridges appear, and separated by grooves. Later, these ridges will persist and the grooves will disappear. And this will lead to the formation of the digits. Okay, same time, there will be a constriction proximal to this foot pad or the hand pad. That will form the wrist joint. Rest of the segment in the middle, you will have the elbow joint and the knee joint forming. So you must think that this limb buds projects at 90-degree. It just stick out of the body at 90-degree. Later, what will happen is there is flexion of the limb buds at the elbow joint and the knee joint. And what will happen is when we talk about the anatomical position, we say that the thumb is laterally placed and the big toe is medially placed. Our the elbow joint is, the flexion is in anterior aspect, and the posteriorly you have the flexion. After the folding of the lower limb, the folding occurs backwards. That is the reason. We have the upper limb rotating medially and upper limb rotating laterally and lower limb rotating medially. Then we have in the 4th week development. This is the first, the rostral one closes, later the caudal.
Your voice is breaking, ma'am.
Will be developed. Is it okay?
It's breaking.
Yeah. Now can you hear?
Yes, ma'am.
Okay. Now coming to the 5th week. The head will grow more, the brain will grow. The kidneys that develop as means the intermediate mesoderm, I have said it is unsegmented, and generations of kidneys will come, but the early generations will disappear, so that a little bit and it will disappear. In the 6th week, there will be development of reflex response to touch for the fetus. The upper limb, this region, the hand plate, the elbow, all this will be seen. The digital rays, digital rays is what I said as ridges, that the primordia of the digits. joins to form the external ear.
Excuse me, madam. We cannot hear you.
And you can see that this
Your voice is breaking.
Ma'am, could you please rejoin?
want me to exit? You want me to? You want me to exit?
Yes, ma'am, and join again.
Now, can you see? Can you hear?
Yes, ma'am.
So, in the fifth week, the growth of the head is the thing that happens more in the where will be the development of the face prominence. The face is formed from 5 prominence that will be there. Then the development of the neck will be there, that is by the pharyngeal arches, but only the 2 pharyngeal arches will be coming. Then the intermediate mesoderm, which we have said as we have the development of the sex glands and series of kidneys. They will be transiently will work for a little bit time and they regress. So this is the intermediate mesonephric ridge that it is called interim kidney, which function for a small period. And in the 6th week, is it okay now? Hello. Yes.
Yes, ma'am, it is.
Okay. In the 6th week, what is happening? There will be little bit of response to touch of the fetus, not fetus, the embryo. And the upper limb, I have said that it develops as a bud, which will differentiate into elbow and hand plate in the upper limb. And there will be development of the digital rays, which I have said as ridges, which form the primordia or the primitive digits. There will be little bit of movement in the trunk and limbs, but it will not be appreciated by the mother. Then later, there will be a little 4 days later, the development of the lower limb also occurs. But what I said is that from the dorsolateral aspect of the embryo, the limb buds arise. So it is the somatopleuric mesoderm that is forming the limb buds. So that somatopleuric mesoderm will form the skeleton and connective tissue part of the limb, but not the muscle. Muscle comes from the somates. So that somate carry the nerves along with it. That is why you have the spinal nerves coming into the limb. Then you have the auricula hillock, which are developed in the region of the head. It is the fusion of this hillock, the external ear develops. Some evidence of this hillock is seen in some of us as small tubercles in the area of the pinna or the external ear. Now, in this, you can see the developing large size of the head, the developing eye, the eye placard. Into it develops the lens placard, again with its ectodermal, the nasal pit. All those are ectodermal derivatives. Even the lens of the eye, it is ectodermal. Then this is the developing head end, the cranial end of the brain, and inside you have the stomodium, where you have the primitive mouth, and you can see the pharyngeal arches. So this development of the pharyngeal arches will develop into the neck region, get separated later. This is the dorsolateral aspect of the body of the embryo, where the primitive upper limb bud is seen. This is the lower limb bud, where you have the in relation to the lumbosacral somates. This upper limb bud is related to the cervicothoracic limb somates. So it will carry those spinal nerves. It will take with it the muscles derived from these somates go into the buds. So it will carry the spinal nerves along with it. So in the 7th, the digital rays will get separated and the digits will become separated. Then you have in the starting of the bones of the upper limb will be start to form. By the 8th week, it will be formed. You can see in this, the limb, this is the hand pad. You can see the digital ray, the construction of the wrist. Later, this area, you will have another construction for the elbow. At the same time, the limb bud having developed that much, only a little bit of construction of the angle joint is seen. No digital rays. So there is a little delay between the upper limb bud and the lower limb bud. Here you can see the development of the face. With the different processes that develop into the to the face. You can see the lower jaw forming the eye, the ear. Now, there are much more development in the 8th week. There is the digits with the fingers will be digits. The regions of the limb, which was only the distal part that was apparent, become all regions will become apparent, and there will be lengthening of the digits also. Ossification of femur. Then I have said that there is flexion of the limbs, so they will approach each other. And okay, that's it. Now, so you can see that head has developed much more. The ear has developed hillock have fused to form the ear, the aspect to the front. So many processes are forming into the to form the face. The upper limb is getting folded. So that is the embryonic period. Now coming to the fetal period, what is happening is there is the differentiation of the different layers and the as occurred. Now there will be in fetal period there will be rapid growth and little bit of differentiation. The organs has been formed. Now rapid growth of it will occur. And you have seen the head is much larger. So in the fetal period, the growth of the head will be a little bit slower compared to other regions. And there is rapid gain of weight. Okay. No. So on the 3rd month, the fetal period starts from the 9th month till the delivery. Sorry, not 9th month, 9th week till the delivery. So in the 3rd month, the head will be the half the size of crown drum length. What's meant by crown drum length? The length of a fetus is measured from the upper part of the head to the between the gluteal region, or the bottom of the gluteal region. That is crown drum length. There is another also crown foot length. That is the standing length. That is from the upper part of the head to the buttock region. Usually the crown drum length is measured during the ultrasound to assess the fetal growth. The face is formed. Then 3rd month, the eyes will come to a normal position. Usually it was in the beginning that it was laterally placed. Then it comes to the front. The length of the upper limb will be more than the lower limb in the 3rd month. The external genital will be apparent, and you will be able to know the sex of the fetus by about the 12th week. The physiological embryo up to this will be seen mostly in the 10th week. It can be disappear. It will go inside the embryo by the end of 12th week. If it persists, it is not normal. That is, if it's persistent still 12th week, it is called the physiological umbilical hernia. Because the physiological umbilical hernia is needed because the gut grows faster than the abdomen. The lower part of the abdomen is late to form. You must have seen in the initial pictures the region of the connecting stalk when with the tail fold, the cloacal membrane and the connecting stalk, it is closer. So that region between the cloacal membrane, which is the later uh, dividing into the anal orifice and the genitourinary orifice, that area, it is not that much developed. So that physiological hernia is needed for the development of the gut tube, because there is no space inside the embryo in the abdominal cavity. So what happens in the 5th and 6th month? We have seen that it is half the size in the 3rd month. Now it has come to the 1/3. The head circumference has come to the 1/3 size of the crown drum length. By the end of the half of pregnancy, it will become half the length of the full term, but its weight is only 1/6. That means at the end of the half of the pregnancy, the length of the fetus is half that. The skin is wrinkled. Why is the skin wrinkled? Because it doesn't, the connective tissue underlying the skin is not that much developed. So there is wrinkling of skin. So that is an indication of a preterm child, preterm baby. Then in the 5th month, you can feel, the mother will be able to feel the fetal movement. That is called quickening. Then you have lanugo hair, that is fine hair that appears over the body, that is called the lanugo hair. Then there will be development of hair in the eyebrows and scalp in the 5th and 6th month. Now, coming to the second half of pregnancy, the weight gain is more. The wrinkles will disappear because of the appearance of the subcutaneous fat. But the head circumference will be decreased, and the crown drum length increases and head circumference will be, upper limb was growing more. Now the second half, the lower limb will be growing more, and it will be, finally will be, lower limb will be, have more length than the upper limb. What is Vernix caseous? They are sticky like substance that is seen over the fetus. That is due to the secretion of the sebaceous gland and the shed of epithelium that will form a greasy substance over the fetus. The 7th month of the fetus is called the viable age of the fetus, because during the 7th month, the baby can survive because the lung alveoli has started developing. So it can exist. It may survive if it is born after the 7th month. In full term, the in a male fetus, center of the abdomen, because I have said that there is a delay in the development of the lower part of the anterior abdominal wall. Then normal weight of a newborn baby, it is 2,500 gram to 4,000. So an average of 3,000. If it is less than 2,500, it is underweight. And the normal length of a baby, it is, full-term baby, it is 50 centimeter. And the baby can go to post-maturity. That is 3 or more weeks beyond. Normal pregnancy period is 40 weeks or 20 days. So what is the risk of post-maturity? There is increased risk of mortality because the baby will be overweight. Because of the secretions that will get dried up and the skin will be dry. So the passage of the baby through the birth canal will become difficult. There will be no lango, the hairs will grow. So there is need of induction of labor. So but in the full term baby, you can see the smooth contour of the baby, the reflex of the baby, the grasp reflex is there. Here it is not that the upper limb, the hand is not in a fist position. And in the foot, you can see that there is no much footprints. But in the full term, you can see that there are footprints. What about the skin in the more than 42 weeks post nature? The baby skin is dry. There is so. After tomorrow, we will going through the placenta and fetal membranes. Hello, can you hear me?
Yes, ma'am.
So that finishes the fetal part. Tomorrow we will, tomorrow, day after tomorrow, we will go to the placenta and the fetal membranes.
Thank you, ma'am. Delegates can now post your queries in the chat box or can use the raise hand feature to ask your doubts directly.
Confused.
No, ma'am, it's clear.
There is no queries.
I think
there is
there are
no
no more
queries.
queries. Okay. Thank you once again, Dr. Geeta ma'am, for sharing your time and expertise with us. We are really grateful for teaching us such a complex topic, and we deeply appreciate your effort in making these complex concepts easy to understand. And a big thank you to all our participants for joining. Your enthusiasm makes these sessions even more valuable. Next session is the part 4 of embryology, and it will be on Thursday, that is 13th February from 6 to 8 p.m. by Dr. Geeta ma'am. Delegates, please note there will be no session tomorrow. See you in the next session. Until then, take care and thank you once again for being a part of today's session. Thank you, ma'am. Thank you so much.
Thank you very much.